Oh, go ahead.
No, I'm saying that sometimes, again, we have to know when not to see someone. If someone is in acute extreme pain, manual therapy is practically the last thing they will tolerate. And you must switch over to helping them find a necessary medium for pain control and not then proceed with manual therapy. I had a patient come in and I said, I'm sorry. I said, I can't and should not touch you in the way you are. I go, that would not be wise and it's not even useful to you.
Right.
Because you have to get your pain under control. And that is the job of your primary care physician.
I remember, you saying that. I remember, I mean, it could have been 15 years ago at this point. I hurt my shoulder working out on a Saturday. And in the middle of the night on Saturday, late early Sunday morning, I woke up in the middle of the night in such pain that I remember having my phone open, actually going to call my brother to take me to like the emergency room. It was just throbbing so bad. But I managed it, woke up the next morning, and I called Robert Lardner. And Mr. Robert Lardner walked into his office on a Sunday morning, and it was a blizzard too. It was snowy blizzard, and you treated my shoulder, but it was so inflamed that there was no hardcore manual therapy. It wasn't, we're going to exercise this. You did some light, gentle manual work. You did, I think you even might have like iced it a bit and did some basic acute care. And then you said, did you take some Advil or Tylenol? And I said, no. He said, why not? Why would you not take some? It never occurred to me. Not that I'm anti-pain medication, but right. It just never, this is acutely chemically inflamed. You need some anti-inflammatory. But I think of this and use this with patient, that story too, that sometimes there's no, I'm just going to dig in and bear it and you're going to rub the hell out of this to make it feel better. There's no manual therapy that's going to be. Sometimes it is acutely chemically inflamed and there's nothing you can do about it. You have to just manage it, decrease the sensitivity, and that was it.
Yes. So because chemical pain, you must be able to go, this is chemical, this is mechanical. Or this is psychological, and find a way to educate yourself enough to know when not to touch and when to say, yes, I think I can help you, or no, we need to get this chemical pain under control, because if I do anything, I will just provoke more chemical pain, and that is of no good to you at all. So yeah, that is really how that went down.
So talk to me a little bit about, your perspective on kind of return to function. Obviously, we're DNS instructors, and for better or worse, there's kind of a connotation that, we're going to essentially, every person is going to be rolling around on the floor and crawling for the rest of their lives with us. Whereas that's not actually the DNS approach. It is to verticalize, to stand, to utilize these kind of movement patterns and chains in actual function and in a more vertical position. So what is, your thought process on that, your perspective on these more vertical positions, more functional positions?
I think that as long as we are true to the process of the chains or loops that are involved, if we stay true to the support points, establishing support points, because that is always the first thing. Can you establish good support points? Without that, the movement is compromised. So
let me actually, sorry, but even before you go on from there, I hear you say, in those positions, we have to establish the support points. From the outside, as well as even me thinking about it now, I think, well, the support points are the feet. that they're established. They're on the ground. That's it. Sometimes it's only 1 foot on the ground. So how big of a concern is the establishment of 1 foot on the ground? It's on the ground. It's established. That's it. Are there no support points? There's no support points in the arms or the upper extremities. They're free in space. Now, I'm, begging the question a little bit, or playing a little bit of devil's advocate, because I kind of know your thought process in this a bit, but just to kind of poke it a little bit and explain to me and everyone kind of, well, it's not as simple. It might not be as simple as, well, your feet are on the ground, so they're supported, and we can move on.
Well, I mean, first of all, when we look at just what happens in standing, the problems that can arise between maintaining a relative subtalar neutral, for example, or alignment. Let's say subtalar centration. Let's not even use the word neutral.
Yeah.
Subtalar centration, in whatever position that might be. The use of the tripod function of the metatarsals. And then, of course, for example, how the excursion of tibia compared to femur, compared to pelvis. Is this well timed? Is it aberrant? So the establishing of the sagittal alignment, the establishment of the coronal alignment, the establishment of the transverse alignment, all these come to play into a well-established fixed point. How the patient uses the feet. Again, which muscles are active? For example, when you are standing on one leg, your foot needs to quieten down. If it doesn't quieten down, you don't have a fixed point. You don't have a foot to stand. You don't have a leg to stand on. Yes. So if the foot does not quieten down, that is a telltale sign that the support point is unstable to begin with, and it will transmit that instability into anything that you try to do. So the first
when
thing
you say
is,
quiet down, I mean, obviously you don't mean no tone. There's no,
no, the tone is there, but I don't want to see the tibialis anterior coming on and off, 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 and the foot, the weight moving from lateral to medial, and then the hallux gets lifted likely, or is not really weight bearing. It's resting for a moment, and then it's weight bearing, then it's just resting, then it's weight bearing. So you see this wavering tone across the foot with no actual confirmation that it finds a stable point that it works
Now
around.
I see what you're saying.
So that is the first thing. So if that is not there, there's no point in doing upright work with this patient, because whatever they're going to do, they'll have to work really hard to find a balance, a point, or stabilization. And there's no good carryover from that to the next session, because they have to work so hard at it. So the first thing is, again, making sure that you have good tripod function of the feet, and that it is efficient, and that the muscles that should be working are working. And let's face it, as I say to people, the 3-month elbow position in prone, or 4.5-month elbow position in prone, can be done leaning against the wall in standing. So you don't have to be lying on the floor to transpose those support points into some kind of modified function. So, okay, you do not have the pubic symphysis as the support any longer. You now have the feet and the elbows against the wall. So it's a big change, but the principle is similar. You've just extended the chains to include the foot. So that is one thing. And secondly, we have to be acutely aware in standing of what is an ipsilateral support axis and what is a contralateral support axis. If you don't do that, then you run the risk of confusing the CNS by mixing up the axes and not really getting it to understand which one is the primary stabilizing axis and which are the phasic uh, uh, limbs, rarely, and so on. So it is really necessary to analyze these things because, crawling is great for the coordination of the contralateral limbs. But in crawling, you are not as laterally shifting as you are when you're walking. That's a whole other ballgame because I must shift my weight over to the hip, and I must balance the torso, which is not attached by a contralateral support point, rarely.
In gait,
So,
in
yes,
standing gait.
Yes, in standing, and other movements that are contralateral but are not gait. We must. A gait is one of many contralateral movements in standing. That's it. And
Yeah.
turning is one of many ipsilateral movements in standing. You can have an ipsilateral function without turning anywhere because that's not what your intention is. But you've got to shift your weight over to one side and establish a lateral axis.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.